TopMedTalk.
This is TopMedTalk, the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. The EBPOM World Congress is taking place this year between the 7th and the 9th of July at the British Library in London. Check out ebpom.org now.
Hello and welcome to TopMedTalk. We are here at the 19th World Congress of Anaesthesiologists in Marrakesh. It's the biannual meeting of the World Federation of Societies of Anaesthesiologists. I'm Desiree Chappell. I am back in the chair hosting this year at the World Congress. I'm excited to be here, but I'm also very excited to have Kate Leslie, Professor Leslie, joining us as our co-host.
Great to be here with you, Desiree.
It is so great to be here. I know with my recent role changing, I stepped away from TopMedTalk and I moved on from North Star, and I have joined Monty Mythen and the team at Becton Dickinson Advanced Patient Monitoring as their Director, Medical Science Liaison and Medical Affairs. So brand new role for me, loving it, but I do have to say I miss TopMedTalk. I feel like we're reconnecting.
The band is back
together. The band is back together. That's right. Kate, it's been a phenomenal meeting. We've been here the last several days, actually participated in different events throughout the week. What are your thoughts?
The thing I love about this meeting is not only its size, 4,000 anaesthesiologists and anaesthesia providers, but also from 150 countries. It's fantastic. So there's colour, sights, sounds, all these different people doing different things around the world.
Yeah.
And I think the highlight so far, though, was the Harold Griffith Symposium. Professor Adrian Gelb, who's a friend of the podcast.
He is a fan fave, if I may.
He talked about it's not good enough to know what's safe.
Yeah.
You have to do it.
Yeah.
And, the next step in safety is how to get anaesthesiologists to actually implement guidelines.
Yeah. And he said, "Can we do it?" was the title. And at the end, he had a big finger pointing, "Will you do it?"
I thought, Adrian for president. It was really a call to arms, wasn't it?
It was. If people didn't leave there inspired, I don't know what else would.
And we're doing an interview with Adrian tomorrow. So you can find that on TopMedTalk.
Yeah, absolutely. And we did a profile on him, a perioperative profile.
We did. So we did that at Anaesthesiology 2025.
Yeah.
And we heard all about Adrian, all the way from South Africa through the UK to Canada to San Francisco to the world stage.
Speaking of South Africa, Kate, we are so excited about our guests that we have with us here on TopMedTalk at the World Congress. I would love to introduce Professor Palesa Motshabi, who is from South Africa. Palesa, please, for our listeners, why don't you tell us a little bit more about yourself?
So I am an anesthesiologist from South Africa. I originally come from a very small town in one of the provinces in South Africa, but I live in Johannesburg now. I'm the academic head of the Department of Anaesthesiology, which is at the University of the Witwatersrand. It's actually the biggest platform in the country, consisting of about 10 hospitals. Oh. So I'm head of academia for the department. I am a cardiac anesthesiologist and an enthusiastic researcher.
Tell us a little bit about some of the research interests that you have had over the years and maybe some of the current projects that you're looking on.
So I started research with my PhD. I had no research experience and I just did the deep dive into research. And my research was on myocardial protection when dexmedetomidine was coming in, and I investigated that in cardiac surgery. And that was the beginning. So once I had done that, and I then went on to become head of department, my vision then was to change the culture basically in the department and have a culture of research with the specialists doing research. And I must say there's been quite a lot of success in that. A lot of young people do research, publish. And once that was done, and that was basically the supervision of research for the registrars, I figured the next step is to start a PhD program in the department. A little bit of I don't know. I think I was a bit crazy.
Those are some of the best ideas how they start, but yes.
Yes. So I was quite fortunate to have, the first 4 specialists say, yes, we will be crazy with you in this project. And Dr. Mullai Slave is one of the first cohort, and they're completing the 4 of them by end of this year. I'm sure they'll be She's writing up, 3 of her colleagues are also rounding up their research. And yeah, my interest particularly is on outcomes in cardiac surgery. So that was that. And now I've moved on to doing continental research.
And what is that? What does
cardiac.
that mean?
So basically, I have just started a cardiac surgery outcome study in Africa, which was launched. It's been a work in progress. It was a little bit slow in getting it off, but we actually launched it in January this year and have 36 countries that we're collaborating with in Africa at different stages of IRB and starting their data collection. So that's quite an exciting next step. While, it's a progression. So that's where I am at the moment. It's just research keeps you alive. You ask the questions, you will do the investigation, and it gives you so much satisfaction, I think.
One of the things that we were talking about yesterday was your work to foster that and having that research lens within your department and helping foster the up and coming doctors behind you kind of to continue that.
Absolutely, yeah. That's why today, in this Congress, we've got probably more than 10 abstracts from our department, and it's all different research projects that are being done. It's the livelihood of academia, and people outside of anything else, the hard work and that, coming to a Congress and presenting your work really is such a rewarding experience. So that's where we are right now. Yeah.
Well, you have brought one of your students with you today to talk to us about one of the projects that has been done under your supervision.
So Dr. Mullai is one of the consultants in the department. And when we started this project, she came up with an idea. And I must say, when she did come up with an idea, I thought, I'm not quite sure about this. But it's amazing how the questions you have on the clinical platform actually then lead into the research. And she basically came and said, look, anecdotally, there is something in the hemodynamics of HIV-positive women when we give them spinal anesthesia. And we looked in the literature and there was really a void in that area. And I think perhaps because in Africa and in South Africa is where HIV is predominant, you wouldn't be able to find data anywhere else. Yeah. So that took a little bit of digging. There was really scanty literature. But we then, wrote the proposal and she presented her proposal. It got through postgrad and she started the data, then presented the data, a grant application.
Oh, yes.
To Edward Life Sciences. And I'll explain that a little bit. Traditionally, the way we do blood pressure monitoring is with an NIBP, right? It's very rare that you will be doing arterial blood pressure monitoring in pregnant women. There's not reason enough clinically to do it, even though you may be seeing the blood pressure drop. So that was going to be very difficult for us to get it through the ethics committee to say, just for the study, we would like to do an arterial blood pressure monitor. That's doing harm to patients because you're just investigating. So it was really an opportune moment to then partner with Edward Life Sciences to use their non-invasive hemodynamic monitor to do this study so we can get reliable beat-to-beat blood pressure over that period that we had defined and be able to look at this closely. Dr. Mullai will then speak about, how else we conducted the study.
So Mullai, it's so great to have you on the podcast.
Thank you for inviting me.
Can you tell us which population you chose to study?
Okay, so we chose to study the HIV-positive women at Chris Hani Baragwanath Hospital in Soweto. It's the 3rd largest hospital in the Southern Hemisphere and our largest teaching hospital. It's a 3,000-bed hospital, and the most common procedure performed there is cesarean section. And unfortunately, up to a third, 25% to a third of our patients are HIV positive. And so we definitely see the quantity of patients that are required in order to answer this study question.
And so do these women generally find out about their HIV diagnosis when they're booked for their pregnancy, or is it congenital, or have they found out between those two times?
Unfortunately, the incidence is still quite high, even up to now with all our prevention measures that we've been doing. So a large number of women do find out at the clinic booking, because HIV testing is mandatory. When they go to the clinic to confirm their pregnancy, they also run a batch of tests, including HIV and syphilis.
Yeah.
And so whoever is found to be HIV positive, they initiate them on treatment immediately, So quite a number of them do discover the status there, but others also discover prior to that, or if it could be their second, third or fourth pregnancy. Some are already aware and already on treatment. But by and large, by the time they arrive in theatre, all of them have had a test, and if they have had a positive diagnosis, are on treatment.
Yeah, because I think after we hear about your results, we might circle back to the mechanism.
Yes.
And that will depend on sort of how long they had a viral load with HIV.
Yes.
So you got your cohort of patients and they were having their cesarean section. What did you monitor?
So we would then do the normal standard monitoring, which is, as Prof said, oscillometry, non-invasive blood pressure monitoring, which is performed every minute. And the SATS probe and ECG, that's standard. And then in addition, we had Edwards Life Science Hemosphere monitoring, which had clear site cuff that we were using, a finger probe for non-invasive cardiac output monitoring, stroke volume, systemic vascular resistance. So all the hemodynamic parameters were available to us in theatre to monitor our patients, both the HIV positive and the negative ones, because we wanted to compare the differences between the two groups.
And were the anaesthesiologists or anaesthesia providers blind to the additional monitoring? Or were they able to see it?
They were able to see it, which actually turned out to be a fantastic teaching opportunity for a lot of them, because a lot of them are not familiar with non-invasive cardiac output monitoring. And so we did explain to them that we're going to be using this non-invasive cardiac output monitor. It's up to you whether you would like to learn about how it works, but it's not going to affect the management that is going to be done with the patient. They basically pretend it's not there, but if they want to learn more about how it works and what is available on the monitor, then we did explain to them, this is how you then get an arterial line trace out of this finger probe. This is how you then look at your vascular resistance. These are the different offerings. And it was so exciting to so many of the registrars to have that available in theatre.
So what's the normal vasopressor or inotrope that you use during cesarean section in South Africa?
By and large, we use phenylephrine as our first choice, supported by evidence to show that it decreases fetal acidosis compared to other drugs such as ephedrine. But we do have other drugs available as second-line agents, ephedrine and then adrenaline as well.
So was there any difference in the choice of agents between the two groups?
Actually, there was similar usage according to the results of our study, that the use was similar between the two groups. There was no statistic or clinical difference. They actually had the same doses that were used between the two groups, yet one was hypotensive compared to the other.
So it is reassuring that the types of drugs that were used are similar in the two groups, even though the anaesthetists were not blinded?
Exactly.
Because you could imagine that if they saw cardiac output was low, they might give an inotrope instead of a vasopressor. So that's great. So cracking on, because we can't wait.
I know, I'm
can we? Desiree's on the edge of her seat. What were the main results?
So we did find that HIV positive patients had significant hypotension compared to their negative counterparts. So the HIV positive patients had an incidence of hypotension of 68%.
And how did you define hypotension?
We defined it as a systolic blood pressure drop of less than 100 millimeters of mercury.
To a systolic under 100?
Anyone whose systolic was 100 or less, from 99 onwards, would be confirmed as a hypotensive patient. Yes.
Desiree, the definition of hypotension is a topic that we talk about all the time.
Topic on its own.
Isn't it?
Even for us to get to that value, it took quite a lot of research into what would be best to identify hypotension and what others were using in the country, because everyone has their own definition, really.
But aren't there some pregnant women whose baseline blood pressure is under 100?
it can happen that your baseline blood pressure is under 100 if you're already hypotensive by the time. But a normal, healthy pregnant woman should have a systolic above 100, and we did do baseline blood pressures on all our patients pre-anesthetic, and then we compared that going on for 60 minutes post-operatively.
So the incidence of hypotension in one group was
68% in the HIV positive group and 64% in the HIV negative group. And not only that, but the cardiac index was also lower throughout the 60 minutes in the HIV positive subgroup compared to the HIV negative subgroup. So they had less cardiac index and their heart rates were also lower in the HIV positive subgroup. So already you can see that a lot of the determinants of the blood pressure are decreased in HIV positive women compared to the HIV negative ones. And then the question becomes why?
Yes. Well, so HIV has cardiovascular effects, doesn't it? But Desiree, you know lots about this.
Well, one of the questions, some of the other things that I was learning about as you were telling me about this earlier was that you looked at several other parameters too. And before we get into kind of mechanism, why don't you tell us about some of the other things you were looking at?
So along with the question of whether there was a difference in the hemodynamic profile of HIV positive women, we also asked ourselves about the question why, and we tried to see if we could answer it from the outset. We did echocardiography, transthoracic speckle tracking echocardiography, which is a special type of echocardiography where you can determine ventricular strain using a certain profile on the ultrasound. So we had to locate a very advanced type of ultrasound with speckle tracking ability in order to quantify LV strain. So we did a full echocardiogram on every patient. We did pro-BNP cardiac testing, cardiac biomarker testing, and then we also tested their autonomic system with the autonomic survey symptom score that we did on all the patients. These are part of the avenues we thought might give us an answer as to what the reason might be physiologically, why there would be a difference between HIV positive and negative patients.
And so what were some of your findings from that?
So we did find that HIV positive patients did have stiffer ventricles on the echocardiogram compared to the negative patients. We found the drop in cardiac index as well. But the other ventricular parameters were actually quite comparable between the two groups. So the main finding was the stiffer ventricle or the mitral EA ratio, which was different between the two groups.
Does that resonate with you and as a cardiac anesthesiologist when you treat HIV positive patients?
I must say I didn't expect the ventricular effects.
Yeah.
The vascular effects we're quite familiar with because in cardiac surgery we do tend to see a lot of patients who are HIV positive come with aortic disease, aneurysms, sometimes dissections, very difficult to work with because of just how friable the tissues are by the time they come to you. Yes, quite friable. In fact, when you do, what we'd found is that when you do these patients in major vascular surgery with the vascular surgeons, it's quite difficult when they're deploying devices, to get the devices to sit properly on these water because of how friable the tissues are. And in fact, even when they open, you can see that the vasculitis literally destroys the walls of the vascular structures.
We were talking earlier about there was a similar syndrome with COVID, and there was a bit of an inkling that COVID was causing a similar vasculitis because in some places there's been a little surge in ascending aortic disease. So what are you going to do with your results?
One thing that we've identified is that there is a need for much more research in this area. And I'm hoping that first and foremost, the study can be replicated in larger numbers, more centers. If it can become a multi-center trial, that would be lovely because then we can really have the rigor, the scientific rigor behind it to back up our findings, to confirm what we found. The thought has always been the end user, the patient.
Yes.
What can we do to make anesthesia safer for HIV positive women? How can we save the life of the woman sitting in front of us? And for me and Prof, the future looks like creating machine learning algorithm that can predict who is most at risk for hypotension in this cohort. If we can create an individualized algorithm that can then predict high-risk patients and then suggest, for example, continuous hemodynamic monitoring or maybe even preemptive vasopressor use, and then suggest in terms of management who would benefit mostly from that therapy, then that's where we want to go. We want to go with machine learning algorithms to then produce something that we can put in clinicians' hands in order to assist decision making and clinical bedside approach to decide who is it that is going to benefit the most. And so that's actually something we're already working on.
We often discuss how this is terrific monitoring, made by our sponsor. It's really, really good at measuring blood pressure and other things continuously and providing the anaesthesiologist with more information, and it also helps them prevent hypotension.
Yes.
But whether it makes any difference to any patient outcomes is the real question. So in cesarean section, most of the women, they would have short-term problems, vomiting and feeling faint, and, they want to enjoy the experience, not have their head in a kidney dish, But, they recover and they don't have any bad effects from the hypotension that we know of. And the baby, I guess, is the real organ or monitor that we're looking at. Did you measure anything about the fetus or the neonate?
Yes, we also looked at the APGAR scores in the neonates to compare how the children did after delivery. And we actually didn't find a difference in terms of the APGAR scores in the neonates, which makes sense because we have a team on hand to resuscitate. There were some who had a lower APGAR compared to others, but we couldn't definitely associate that with hypotension. But I think it could also be because it's so multifactorial. A lot of the patient's indication for coming to theatre is fetal distress.
Yes.
And what caused that fetal distress preoperatively is also a question. Is it
bleeding?
Yeah,
is it
absolutely.
protracted labor?
Yeah.
Dehydration. Hypotension can exacerbate that because this is a fetus who's compromised already, and the flow through the placenta is not autoregulated.
Right.
And so it's directly proportional to the mean arterial pressure. So a patient who's hypotensive then with a compromised fetus can have an exacerbated effect on the fetus. But in our study, we couldn't prove that. That's why I say we need so much more research. If we had the backing to do this on a much larger scale, say maybe 5,000 patients or something, then we could definitely find associations.
I also think that in the beginning, you're trying to create a baseline.
Yes.
Because first we didn't know what was really happening. To prove that, in the beginning, the fetal outcome wasn't central to what we were doing, which is something that you then go back into. It becomes a build-up. Importantly for me is just seeing the benefit of having a continuous non-invasive cardiac output monitor in pregnant patients who, yes, for the most part, whatever they experience is short-term. But in these women, if something goes wrong and goes wrong properly, often you lose them on the table. So to have that modality of actually monitoring them continuously and seeing these differences doesn't just become a modality in HIV-positive patients, but you start thinking about eclamptics.
Yes.
And preeclampsia.
For sure.
And the scope then becomes a little bit bigger because now the benefit has been shown in terms of monitoring to say this is how this is helpful.
Yeah.
And you start looking at a population of patients in this particular area.
And specific to HIV, we're very fortunate in the U.S. where I practice. I mean, our rates of HIV have gone down over the years. We don't experience the same way that the rest of the world does. So I'm a little bit ignorant on it, but to kind of flush out what you were saying, Kate, about outcomes, understanding the difference between an HIV pregnant mother, intraoperatively and postoperatively, you said they're higher risk. If things go bad, it goes really bad. But are there post-op morbidity worse in HIV patients? I mean, are they experiencing adverse outcomes differently than a woman that is HIV-negative?
Yes, definitely. There's been research to show that HIV-positive women do experience more adverse effects, longer hospital stays, more surgical site sepsis compared to their negative counterparts.
I think it's great because this sets us up for that exact question. Like, does it actually make a difference? Because that's what we want to know. I mean, we don't want to do anything that doesn't really make a difference in the long run. But I think your work is fantastic.
And I must say that that component is still there in her proposal, but we had to hide it. It was, can we just stop
You
here?
hid that text. Yes. Strike through for the moment.
No, that's the beauty of research.
It
you know,
is.
you can go all the way with it. And I think that's also the beauty of collaborations, which make it possible for us to be able to answer those questions. You know, I think like post-grad said, you know, a little bit at a time, you know, we've done the first part, which has been a huge success, you know, and then we're going to move on to the next part, hopefully.
We set it up for
Exactly.
the future.
Yes.
That's absolutely true. Ladies, I can't tell you how much I really appreciate you sitting down with us. I know the World Congress has been so busy for you all, doing lots of presentations and the like, but to share the story is really important. Many of us don't appreciate, but are still taking care of HIV pregnant mothers. So we appreciate the work that you've done. Cheers to you all. Cheers.
Thank you so much.
And thank you for listening to Top Med Talk. You know, you can always find us at topmedtalk.com. We're on all your favorite social media platforms. We're also on YouTube. Wherever you find us, please do give us a thumbs up, give us a like, send us some feedback. We always love to know what you guys are thinking and what topics are interesting to you. And Kate, thanks for letting me sit in here to join you on the podcast.
It was a very great pleasure.
I missed it, and I miss hearing from all of our listeners, but do appreciate it, and hopefully you'll have me back.
Absolutely.
All right. And we'll have our two wonderful guests back at some point to hear about the future. So thanks so much, everybody, for listening. Cheers.
Cheers.
Thank you for inviting us.
TopMedTalk. TopMedTalk is the broadcasting arm of EDPOM, evidence-based perioperative medicine. Join clinicians from around the world at EDPOM World Congress 2026 between the 7th and the 9th of July at the British Library in London. 3 days of evidence-based perioperative medicine, global insights and expert debate, featuring speakers including Michael Marmot and Ken Rockwood. Go now to edpom.org. That's edpom.org.